The trial that we had showed was a trial using Ropeginterferon, which is a novel form of interferon in use for myelofibrosis. So in that study, we had 7 patients who were in the higher risk category, who had DIPSS intermediate 2 or high risk. And then there were 3 patients who were early myelofibrosis, and a drug that is currently FDA approved in Europe for polycythemia vera, and has some significant benefits above and beyond what we have seen in some other treatments, and that it can, at least in polycythemia vera, has been shown to reduce some of the clonal burden associated with the disease, meaning that the JAK2 mutation goes down. As well as have some really long-term durable effects. And that was actually shown. There was a nice abstract in the polycythemia vera section that was reviewing the long-term benefit of using Ropeginterferon in patients with polycythemia vera. So the use in myelofibrosis, the hope would be is that perhaps using it, we could achieve some of the similar benefits in terms of reduction of clonal burden, as well as potentially even reduction of fibrosis. And that was a major theme that was seen this year in a lot of the abstracts presented, was really looking at some of the more disease-modifying effects that can be achieved with different treatments rather than just the symptom burden improvement that we historically had been looking at. In this study, we enrolled 10 patients, as I said, with 3 of whom who had early myelofibrosis and 7 of whom had myelofibrosis that had already was refractory to ruxolitinib. So this was a single-arm study. The primary endpoint was to evaluate for response in myelofibrosis is based on the defined response criteria. And the secondary endpoint was to look for tolerability. So patients were initially enrolled. They were started on a very low dose of Ropeginterferon at 50 micrograms, which is quite a bit lower than the doses that have been used for polycythemia vera, and gradually increased to the maximum amount of tolerability. We included patients who had evaluable myelofibrosis, so they had to have a splenomegaly, an MPN symptom score of greater than 10, or a hemoglobin of less than 10. And they had to have a clear evidence of having myelofibrosis. They were excluded if they had poor organ function or if they had chemotherapy or radiation therapy within 2 weeks. Other things that were of concern are peripheral neuropathy as well as uncontrolled depression. The median age was 69. The majority of them were male, 6 were male, 4 were female, and they all had reasonable ECOG performance status. Half of them had primary myelofibrosis and half of them had secondary. And the median time since their myelofibrosis diagnosis was 13.4 months. 5 had primary or previous therapy for myelofibrosis and 5 were therapy naive. The driver mutation was JAK2 in 3 of them, calreticulin in 4 of them, and MPL in 3 of them. So there were no triple negative patients. And the bone marrow fibrosis was either moderate or severe. When we looked at the adverse events associated with this, there were the grade 3 adverse events that were most common were anemia, low white blood cell count, and that those were experienced by 4 and 3 people respectively, and the leukocyte count decreased, which is what we would expect. However, in terms of other grade 3 effects, just one patient had, there's one patient each for dizziness, insomnia, and a CD4 lymphocyte decrease, which again is expected. At the time that we reported this, there were 4 patients who were still active on the study. The median time of follow-up was 29 months. And the best response that was noted was a partial response in 1 patient. 2 of them had a clinical improvement based on TSS, and 4 of them had a clinical improvement based on spleen. 2 of them just had stable disease, and 1 actually that did not have any response had progressive disease. And the number of cycles that they were able to, that they had were 7. Average cycles was 7.5, and it ranged from 3 to 47. And the reasons that patients went off treatment when it was alternative treatment, 1 went off from an adverse event, which was atrial flutter. 3 of them had disease progression, and 1 of them was felt to be receiving no benefit and probably having some disadvantage based on the fact that their hemoglobin had gone down, although it didn't actually meet criteria for an SAE so was removed from the study. So I think what we've learned from this is again, is some a very sort of preliminary trial. It was single center, but we did see a couple of things that were notable. First of all, that patients really tolerated this treatment quite well, showing a lot of promise. And I think that they tolerated it quite well, and we actually did see some meaningful responses for patients. And that, coupled with the fact that we do know that there's a potentially disease-modifying effect from this, I think make it a very attractive choice to study further, especially in patients with early myelofibrosis who really may benefit from some of the disease-modifying effects of the drug.